Okay, so we'll talk about NeuroCardiac-Guided TMS to target the depression network, possibilities for rTMS treatment stratification. So the main topics I want to focus on is how can we optimize clinical efficacy further? And I think we already know that there's various ways to potentially optimize clinical efficacy. A lot of talk has been about specific stimulation parameters that we can play around with. The percentage of the motor threshold, the number of stimuli, different locations. But I want to take a slightly different angle here. One of the things that we'll talk about briefly is combining treatments, which I think is something that should deserve more attention. A second aspect, I think, is a little bit of a detour going into territory of medication as well. But as you'll see, with a good reason to more learn how prediction stratification can be a very important feature in psychiatry in general, and where the place of TMS of that could be. And then finally, we'll end off with TMS targeting, and mainly focusing about neurocardiac-guided TMS and how this specific application of neurocardiac-guided TMS might be a possibility within the suite of rTMS approaches to more individualize and personalize the treatment as well. So this is a picture we've shown several times, and I think here we see delineated pretty much the depression network. We've seen these terms pop up in the DBS research and many other studies as well. And I think this is the current conception of what most people would conceive of to be the depression network, and at least the key hubs within a depression network. We know it comprises the dorsolateral prefrontal cortex, the DLPFC. There we aim with TMS and TDCS to modulate that specific area. We know from the DBS literature that deep brain stimulation aimed at the subgenual anterior cingulate, or CG25, is an effective treatment. And so that's a key hub within a network as well, where we know that the subgenual anterior cingulate is mostly involved with emotional processing. And we also know that the vagus nerve is partly involved and implicated in the depression network as well. We know that people with heart disease have a higher likelihood of developing depression, and people with a depression have a higher likelihood of developing cardiovascular disease. And we also know that vagal nerve stimulation is an accepted treatment in the treatment of treatment-resistant depression. So this network and these hubs, these nodes within the network are very well described, and I think very well accepted to play at least some role within the network. Of course, not in a localizationistic approach that depression is localized here, but more as a functional network that should function in an optimal way in order for behavior to normalize as well. So here with this backdrop, what we also see is that when we combine the psychotherapy that supposedly acts more on the subgenual anterior cingulate level with the TMS that is aimed at the dorsolateral prefrontal cortex, we might envision that the clinical benefits will be enhanced as well. When this photo was taken, which is about 15 years ago, we didn't know that. So the reason why we started in this kind of setup, where the psychologist would combine the psychotherapy with the TMS, that was mainly for the purpose of reducing the load and the cost for the patient. And we would get reimbursed for the psychotherapy and not for the rTMS. But when we started publishing our findings, we more and more found out that somehow the clinical benefit tended to be a little bit on the high side, which we couldn't explain fully at that point in time. Interestingly, when research progressed, we see this study by Lindsay Marwood et al. In 2018, where they conducted a meta-analysis that specifically looked into the pre to post-treatment effects as imaged with an fMRI scan as a result of psychotherapy. And we couldn't have conceived of this to be matching up that nicely, but you can see there the rostral anterior cingulate, which to some degree extends into the subgenual anterior cingulate, so they overlap to a substantial degree. So we see that one of the major effects is actually taking place at the level of the rostral anterior cingulate or the subgenual, which is indeed what we would have hypothesized about. So another interesting study, which is a really controlled study, is where they actually designed a task, and this is a kind of neuropsychological task, where they, people had to do specific neuropsychological manipulations, and that was specifically aimed at activating rostral anterior cingulate activity. On the bottom right-hand corner, we see that when they these people were doing the task pre and post, that using imaging, indeed specifically the RACC lighted up. And so the task was in that sense designed quite effectively. So what they've done in this test, they randomized people to real TMS and sham, the sham task, so to say, a sham task and real TMS, or both sham versions. And what we can see on the right-hand side is that only when they combined the active task together with active TMS, they saw the best clinically significant response in the treatment of depression. They're really suggesting and demonstrating in a quite causal way that combining these two treatments enhances clinical efficacy. So when you at the same time activate your rostral anterior cingulate or subgenuine anterior cingulate and combine that with rTMS, you see an enhanced clinical benefit. So we think that's also exactly the same what's happening with the combined treatment of psychotherapy and TMS. And these are the data that we have collected so far, almost 200 patients, and we see that the response and remission rates are 66 to 56%, which is based on a multi-center effectiveness data trial. When we follow up patients for about 6 months, I think it's very important to also see their sustained benefit. So about 2/3 of the patients are showing sustained response after a follow-up period of 6 months. When we contrast this to several other comparable, equally sized studies, like effectiveness studies, we see the Bloomberger trial, the Carpenter trial, and the Fitzgerald trial. And if you specifically focus on the remission rates there, we see they vary between 30 to 31 to 37%. So when we contrast that to the 56% that we have seen, I think it makes a lot of sense to at least consider combining psychotherapy at the same time with applying the rTMS. As we've seen before, I think quite often high frequency, low frequency TMS, when we separately compared them, there was not a difference at all between these two types of treatments. So when we then look at the whole landscape of depression, where do specific treatments fit in this whole landscape? Then I think on the far left-hand side, we see psychotherapy as a monotherapy. And here we're aiming at, say, first-time depressed patients that present with their first depression. We see response remission rates of about 40 to 50%. When we compare that to the third treatment, which is antidepressant treatment, citalopram, as obtained from the STAR-D trial, we see quite similar response and remission rates. Only when we combine the two treatments, psychotherapy plus antidepressants, then we see a clinical enhancement in especially the response rate going as high as about 70%. And this is also why the current treatment guidelines are suggesting to combine pharmacotherapy with psychotherapy. So now the interesting thing comes when we move from antidepressants more to the right-hand side, to the 1 failure, the 2 failure, and the 3 failures. Then we'll see that the clinical response is actually tapering off as a function of what we call treatment resistance. And so when people have failed 1 treatment, 2 treatment, or 3 treatments, their likelihood of responding or remitting to any treatment, even if it's a different mode of action, is tapering off to about 15%, which is a very low likelihood of responding. If we then zoom in on the right-hand side, when we look at rTMS monotherapy or rTMS plus psychotherapy, then we can learn 2 things. On the one hand, it's not a big surprise that combining treatments enhances efficacy. We see a similar kind of approach with the psychotherapy to antidepressant. But secondly, and that's visualized in this picture, where should be the place, in my view, of rTMS for the whole landscape of treatment? I think that's actually after 1 failed medication. So we've used this data and presented this to insurance companies in the Netherlands as well, and they actually agreed with this notion that currently the threshold for people to qualify for TMS treatment in the Netherlands is having failed 2 evidence-based treatments. And having failed 2 evidence-based treatments implicates 1 evidence-based way of psychotherapy and 1 medication. Or if people really refuse taking medication, as long as they have tried 2 evidence-based psychotherapies, they would qualify as well. And so I think this is really the sensible place from a response remission rate perspective, where the most optimal place for TMS in the landscape of treatment will be. Okay, so now we have mainly zoomed in on the left-hand side, what we see visualized here. We've talked a lot about one-size-fits-all psychiatry. We have one disorder as defined by the DSM-405 called depression. We apply a treatment, and the treatment either results in an adverse event, in no benefit or benefit. And so far, from that perspective, we're doing pretty good. And we see that the response remission rates are doing quite a good job, but still we're far away from the 80, 90, maybe 100% where in the future we would like to be. And I think then the next question will be like, okay, how can we move to a future where actually 90 to 100% of the patients will start responding? And therefore, I think we'll talk a bit more about stratified psychiatry and precision psychiatry. And so the question that I want to pose here is what should be the future? Should it be about prediction or should it be about stratification? So I first want to focus a little bit on precision psychiatry. I think most people in the research world, but probably clinicians as well, would think that precision psychiatry is really where we want to go. We can see that with precision psychiatry that we take a lot of biological assessments, metrics, ranging from genetic data to brain imaging data to TMS evoked potentials, whatever we can conceive or think of to collect a data set that will give us information to provide an individualized treatment to an individual. And so that could mean that for the woman in the yellow dress, that would implicate psychotherapy, and for the man in the pink clothing, that means rTMS. And so that is really a one-to-one matching of one individual to one treatment, which I think is interesting, but maybe problematic as well. And that's what I want to visualize in the next couple of slides. So this is a very often quoted meta-analysis which was published in the American Journal of Psychiatry. And here they asked a very simple question. When we look at quantitative EEG as a predictor for treatment response, how well is that performing and is that ready for clinical practice? On the left-hand side, we see what we call a receiver operator curve, which tells us something about sensitivity plotted against the false positive rate. So the best option would be the blue dot in the left-hand corner, which means your sensitivity is 100%. And so you really identify everyone that would be a responder, but your false positive rate is very low. And keep in mind, that is a very important notion, because if you can predict with a very high sensitivity, but your false positive rate is about 50%, that basically means that if you tell someone they're a non-responder, they still have a likelihood of responding that is 50%. And so this is where the ethical and the ethics come in. If you are faced with a patient, you need to be absolutely sure that if you tell him he will not respond and you refer him out, that he will not be responding at all, because otherwise, ethically, you cannot withhold an active treatment to someone. So that's how you can read this picture. If you read the picture overall, you would say like, well, all the dots are clustering in the right top corner, so there's some promising signal there. However, the conclusion of these authors was something completely different. They concluded that qEEG does not appear to be clinically reliable for predicting depression treatment response. And the main reason for this was the following. And here we see a funnel plot, which is basically showing you the normal distribution of the effect sizes of all the studies that go into it. And you would expect that these are normally distributed. But where the question mark pops up is really that there's a lot of missing studies in the low effect sizes. And this is something we refer to as publication bias, which means that if you have a good result, you'll publish it. If your result is not that positive, you don't publish it. And that's actually a kind of behavior that is really, not being functional here, because that means that we cannot reliably interpret any meta-analytical data derived from qEEG-based studies. And so I think this is a very important notion, and it implicates that we need to focus more on replication, prospective replication, and also publish the null findings, which is a very important lesson here. So when we focus on this study, this is a very famous study. I don't want to put this study up here because it's a fact, because I think if you look up the DINGA study, which is a very high-powered replication attempt that actually failed to replicate the study. The main reason why I'm putting this example up here is to illustrate to you, like, well, how would a biomarker in rTMS actually work? So we'll not zoom in too much about the methodology, which was based on functional connectivity as derived from fMRI scans in about 1,000 patients with depression. But let's zoom in on the left-hand side. From this very sophisticated data-driven analysis, they derived 4 what they call biotypes. And so 4 types that are grounded in biology and neuroimaging in this sense, called biotype 1, biotype 2, 3, and 4. So the final test they've done here is to what degree are these different biotypes responsive to dorsal medial prefrontal cortex TMS. And they found that biotype 1 and biotype 3 responded very well to TMS treatment. And so compared to biotype 2 and 4, you would think that's a pretty good contrast. So let's now do a kind of mind game and say, okay, we now will use this test prospectively in our clinical practice. We'll refer everyone out for an MRI or whatever the biomarker at hand will be. And then we say, okay, we're going to really advise people and recommend people to do TMS when they fit into the biotype 1 and biotype 3 category. So our response rates are going up, but now this patient walks in with a biotype 2 or a biotype 4. What are we going to do? Are we going to tell, well, sorry, TMS is not the right treatment for you? We can see in this graph that even though they have biotype 2 or 4 and they have a reduced likelihood of response, that still there's a 30% likelihood of them to respond, which could still be higher than the average antidepressant they might qualify for. So is that clinically meaningful? Can we really deny them treatment based on this biotype approach? And my answer is no, because we are not certain enough to really give life and death decision, as I like to call it. Because prediction relies on life and death kind of predictions, where you need to be absolutely sure. And that's why we need very high sensitivity and very high specificity as well, which is not sensitive enough in this type of analysis. That's in my view where I think prediction is going to be way too problematic. So in order to achieve that kind of future for predictive or personalized psychiatry, there's many things we still need to do. Replication is a key. Prospective replication, we need to prospectively validate it in clinical trials as well. We need to publish null findings. And then I think we might, in the meantime, start thinking about a kind of intermediate step, and not diagnostics, not personalized medicine, but I think that will be the stratified medicine approach. So I'll show you some examples of that in depression. So as some of you might have read or seen before, that this is the iSpot study, one of the largest biomarker studies that has been conducted. The interesting thing here is that people were randomized to 3 different treatments. So 1,000 people that were very well phenotyped before treatment, and they were randomized to escitalopram, sertraline, those are 2 SSRIs, versus venlafaxine. And then we followed them up for about 8 weeks to see who responded to treatment, and we could tell based on baseline data from the EEG, could we predict treatment response to some people better than to others. So one of the main findings from this study, and many papers have now been published based on this data set, but I think one of the best examples we see visualized here is that when we look at frontal alpha symmetry, the first conclusion here is that we could not predict anything for males. And so we find a kind of sex-specific biomarker prediction that we can only predict treatment response and remission for females. So when you look at the 0 on the left-hand side, the 0 means that your alpha power is equally present both in the right and the left hemisphere. When the value shifts to a positive value, we see that you have a more right dominant frontal alpha. And when it shifts to a negative value to the left, you have a more left frontal alpha symmetry. So what we see nicely visualized here is that those patients that responded to the SSRI escitalopram sertraline had a positive value, whereas those who did not respond to this treatment had a negative value. When we then zoom into the venlafaxine and the rTMS results, and the rTMS is like a post hoc added analysis, we see no such effect occurring there at all. Due to this lack of an effect, we know that if you have a negative frontal alpha symmetry, you might have a larger likelihood of response to venlafaxine or maybe even TMS in this case. And so when we played this game, when we did a kind of simulation, and we stratified people to an SSRI if they had a right frontal alpha symmetry, or an SNRI in case of a negative frontal alpha symmetry, then we saw an enhancement of the remission rate from 46 to 60%. And so I think a very interesting and exciting example of how stratification rather than prediction would have worked. And so we're not telling people not to take a treatment, we're assigning and enhancing the likelihood to be responding to the right treatment. We've now actually prospectively tested this as well. So this is the first study in a large clinic that we conducted, where we used this very simple algorithm in a large psychiatric practice. We first had the psychiatrist do prescription as usual, and that's the controls PAU. And also we contrasted that to QEEG informed stratification. And so we used the quantitative EEG, and one of the main factors in here was this frontal alpha symmetry finding, and we then stratified them to a treatment. And to our surprise, because it was intended as a feasibility study, we at least see a significantly higher drop in depressive symptoms. This paper as well is a very large study in Nature Biotechnology, where they applied machine learning to the alpha EEG. And so they mainly zoomed into alpha activity in the brain, and by a very more or less complicated machine learning technique, they were able to apply this algorithm to many data sets. And just to highlight a couple of small findings in here, I think the interesting thing was that if you look on the top right-hand corner, the blue, this predictor could not dissociate placebo response from placebo non-response. Whereas in yellow, we see it did predict a high response to sertraline, and when they predicted low, actually the response rate was very low as well. So they could basically dissociate between 20 to 70% response rates, whether it indicated a low or a high response to sertraline. So predicting response to one treatment is interesting, but what did it predict for rTMS? The interesting thing was when the predictor indicated a negative prediction for sertraline, we can see on the bottom dotted graph that actually the response to 1 Hz TMS was much significantly higher. Whereas if the predictor predicted a good response to sertraline, there was no good response to 1 Hz TMS. And so again, we see a differential prediction between two qualitatively different treatments that can really set us up for stratification. And so we could take this cell as a biomarker, and based on what rolls out, if it's a negative response to sertraline, of course, we're not going to try sertraline, we immediately will go to rTMS. And so I think, again, another example, and we have multiple of these, of a future where it's possible to stratify people to the right treatment. So that really brings me to this intermediate summary, where I think precision psychiatry, although a huge dream, at least of mine and probably of many people, I think we need a step in between where we can already start getting experience with biomarkers and use the knowledge and expertise we have with biomarkers, but then in stratifying people to known treatments within the accepted range of treatments that are all approved for that indication as well. And so here we're stratifying groups of patients to one or the other treatment based on their biological biomarkers. And that's where I think we'll pick up again. I needed this small detour to amplify again the notion of prediction or stratification and how we might potentially start applying that to TMS as well. But of course, also with realizing that TMS is not the magic treatment for everyone. There will be people that might be responding better to sertraline or any other treatment in this whole range as well. So we've seen before that targeting, I think, is a huge issue in the rTMS literature. We see on the left-hand side that long time ago we started with the 5 centimeter targeting method, as it was originally developed, where if you would explain this to a neurosurgeon that we are targeting brain stimulation on a fixed 5 centimeter rule for everyone, that sounded quite ridiculous. So we've now moved away from that 5 centimeter method to a more relative method called the BEAM F3 method that takes into account differences in skull size, differences in head shape to some degree, and thereby considered to be a more effective treatment. I'm telling you, it's considered because there's no study to date that has actually compared the clinical effectiveness of the fMRI or the beam method to the 5 centimeter rule. So we can judge from 2 studies that were actually conducted, 2 separate studies, that the response remission rates are more similar and do not show any preference for one over another. So maybe knowing that these 2 different techniques might be targeting a slightly different area, the question is what happens on the individual level? And that's what I want to explore in the next couple of slides. So one, I think, very advanced kind of imaging approach to finding the right target that has been puzzling me for quite some time, because I think it's a very fascinating approach, is the approach that was put forward by Michael Fox and Alvaro Pasqualeone. In this figure, we see how they were imaging the data. They were actually using a seed region in the subgenuine anterior cingulate. We see it on the bottom left panel in A. And so we have a seed region in the subgenual. And then they're subsequently looking at all the prefrontal areas as imaged with fMRI, and to see to what degree these are correlated or anti-correlated to the activity in the subgenuine anterior cingulate. And correlated or anti-correlated actually meaning if it's functionally connected. Because if the subgenual is sending a signal and the dorsal lateral prefrontal cortex is receiving it, that actually means that there's functional connectivity and these areas are functionally talking to one another. So in very simplistic terms, this could be a potential way to find a highway, the cortical highway to the subgenuine anterior cingulate. And what the data was at least suggesting is that those studies that were most closely targeting this highway to the subgenuine anterior cingulate also tended to show the highest clinical response to TMS. So I think very promising, but this would request an MRI scan for every individual patient. So before we go there, on the right-hand side, we see a first study where they looked at the reproducibility, or say the retest reliability of this metric, because all the data on the left-hand side is based on group average data. And of course, we want to treat an individual patient. Here we see 4 different scans, and I can assure you they're from the same individual. And they have applied the same kind of technique that was applied in the Fox and Pasqualeone approach. And I think, as you can see, is that it's pretty much all over the place. When you specifically look at the dorsolateral prefrontal cortex, it's not a very consistent reproduction of where we should be targeting. So I think this really makes this approach problematic, not only for expense and additional hurdles that are brought up, but also from a reliability point of view. And that's also, I think, why this method, as of to date, has not shown up to become a major application in TMS clinics yet. So that's why we set out to find a kind of different way of targeting this network without the use of an fMRI. And that's why we came up with the frontal-vagal pathway. As I highlighted before, we know there's a lot of crosstalk between the parasympathetic nervous system in depression and many cortical areas. And we know that vagal nerve stimulation is an effective treatment in at least a subgroup of patients that have a highly treatment-resistant depression. And when we really are looking into all the details of this whole frontal vagal pathway, we know that the dorsolateral prefrontal cortex is connected to the subgenual. And the subgenual, there's some studies showing that when you electrically stimulate the subgenuine anterior cingulate, you see subsequent decreases in heart rate as well. So maybe what is a better way of functional connectivity that's stimulating a specific area in the brain results in something that happens in the heart rate? Well, then we know for sure that the whole network is downstream being activated. And in my view, that could be a much simpler and more, better outflow of how this, how the functional network could be activated. So the idea is that by zooming in on one hand on the depression network and looking at the overlap with the vagal pathway, it could well be that maybe this is a more efficient way of targeting the depression network. That's actually what we see visualized in this video. I hope that the sound is turned on high enough, but we see my brain being stimulated. This was actually when we had this idea, this was the first time that we were testing this on my brain. So here we see on the left-hand side, we're targeting the F4 location in my brain, so to say. And on the right-hand side, we're targeting FC4, which is just 2 centimeters more posterior. On the screen, you will see visualized my heart rate in real time, and you will see about 5 seconds of 10 Hertz stimulation. So if this crazy idea is actually true, you would expect a specific deceleration of the heart rate. So the heart rate would go down on one location, and you would not see anything on another location. For those of you who have ever experienced TMS, you would not expect the heart rate to go down. It sometimes can feel like a woody woodpecker that's trying to find a way through your skull, so to say. It feels like a ticking sensation, especially the 10 Hertz, which is not something that would really be soothing or calming or whatever. And so the fact that you find a decreased heart rate is quite specific. But let's see what happens when we started stimulating. First, we start with the left-hand side. Stimulation, heart rate goes down, 70, 69, 68, stimulation stops, and it goes back up again. So here we see about a 5 BPM lowering of the heart rate, specifically during stimulation, which is in line with what you would expect as well, because the vagal nerve, as opposed to the accelerated nerve is more resulting in sympathetic activation, but the parasympathetic nerve is myelinated. And myelinated nerves can much more quickly activate downstream areas. And that's what we can also see in the short-lived effect we see occurring here. Now we're targeting FC4. Let's see what happens. 84, 83. And so we don't see anything happening. If anything, it tends to be an increase of activation, but not as much a specific decrease. Of course, that's an NS1 study. So we now conducted several studies, and here is the first controlled study in about 10 patients. And here I'll show you the methodology as well. So here we see the heart rate in the top panel A, where we basically visualize the stimulation of the rTMS pulses in real time as well. So we at the same time measure the EKG as well as the rTMS pulse. Then we connect the R to R peaks and calculate the time between the two R peaks and plot that into what we call an RR interval. And that's what we see in the bottom side. And the time axis is completely different because these are the RR intervals. So we then basically, during stimulation of FC4, C4, and F4 visualized on the horizontal axis, we can then determine T0, T1, T2, and T3. We found that it was quite difficult to do because if you visualize the RR signal, you see there's a kind of sine wave running through it. And this is a phenomenon very well known as respiratory sinus arrhythmia, or this is also related to heart rate variability. When you breathe in and breathe out, you will see that your heart rate goes up and down at the same time as well. So this is the respiratory component that runs over your heart rate variability. And this variability is making it very difficult to pick up the very small in or decreases during the 5 seconds of stimulation we have. Because an inhalation-exhalation cycle takes about 10 seconds. But we cannot increase the 5-second stimulation due to the safety parameters that we know are valid for TMS. So this is the way we found. We connected the troughs, and therefore we could then look at the slope that was happening by connecting the troughs and thereby taking out the respiratory component of the stimulation. Then we calculate Z-scores, and these were the first results that we found. We found that on the group level that we saw most of the heart rate deceleration taking place for F3, F4. In the control locations C3, PZ, and C4, which are motor area and the parietal cortex, we don't see anything happening. If anything, it's a heart rate acceleration as a result of the stimulation. And FC3 and FC4 were lying in the middle. And so exactly what we would have expected. Also, when you look at the individual level, we see that there's about 80% of the people were most sensitive at F3, which was 60% at F4, and about 20 to 40% at FC3 or FC4. So also suggesting that there's a differential selectivity or specificity, that one subject is more sensitive to stimulation at one location relative to another location. So at this point in time, there's the Neurocon developed this device called the Neuro NCG Engage, which can really synchronize these data and does all these calculations automatically. So it's much less complicated at this point in time. So we then conducted a next replication and extension study where we wanted to validate this in a larger group. We also wanted to target way more locations. We now had like 3 locations in one hemisphere, and we now were targeting 8 locations to see what the topography of this effect looked like in more detail. So the first replication looked like this. So we used 10 Hertz NCG-TMS at about half of the sample. And you can see the healthy controls on the left, which is about 30 people. And I think it's very specifically shown that FC4 and F4 are showing a heart rate deceleration. And all of the surrounding sites, if anything, are showing a heart rate acceleration. And so I think a perfect replication. When we also look at an independent sample of 34 depressed patients, we see an almost identical pattern appearing. And we didn't stimulate C4, but other than that, the other sites were looking quite similar. What was interesting is that we also stimulated at different intensities. We wanted to see if the motor threshold, as we know it from the motor cortex, was identical to the excitability threshold in the prefrontal cortex. However, we found that the heart rate response did not correlate to percentage motor threshold. It did correlate to percent machine output. So this is really telling us that the percent motor threshold is a very poor correlate of prefrontal excitation threshold. And so maybe, and that's one of the next things that we are aiming to develop, maybe we can use this technology as well to individualize someone's prefrontal threshold by looking at heart rate rather than looking at the thumb response or the motor evoked potential. The test-retest reliability was reasonably good at 0.5, which I think is a pretty good test-retest reliability for the individuals as well. So then, of course, replication is important. And here we see, I think, for the first time on the left-hand side, an independent replication from a group from Australia, from Paul Fitzgerald and Marina Carr, where they showed identical effects of this type of stimulation. And on the right-hand side, we see the first individual participant meta-analysis that confirmed the results as well. But in addition, also tried to look at laterality differences. Are these effects the same for the right hemisphere relative to the left hemisphere? And the very simple take-home message is that there were no laterality differences there. So when we were conducting the study, we actually came to talk with a couple of colleagues from Canada who were conducting ITBS. And these were the same people that were behind this very large comparative study between ITBS and 10 Hertz, the Bloomberger trial. And they had a lot of data where they were conducting ITBS, but they wanted to investigate to what degree accelerated TMS would benefit from having 2 sessions immediately after one another, or having 2 sessions separated in time. So they actually included a kind of sham stimulation and real stimulation, had 4 blocks per individual. So they were also able to collect a lot of data like blood pressure data, EKG data, and of course we were dreaming like, well, this could be potentially very interesting data to do a further replication, but also extension to ITBS. So here we see visualized a 3-minute time scale. The RR plots are visualized for these 3 minutes, and we received the data in a completely blinded fashion. So they throw the data at us and said, well, this is it. We'll tell you what is sham and what is real once you have analyzed the data. And I can assure you most of the data look like this. So I think you can already see 2 major differences. When we look at the first panel and the fourth panel, we see there's a much lower variability occurring relative to the second and the third panel. And keep in mind, this is one subject and the same subject. So that means that the heart rate variability was quite significantly enhanced for the second and third stimulation relative to the first and the fourth. But especially when you look at the slope in the beginning, and the slope meaning that you have a high heart rate that decelerates into a slower heart rate, we see that the slope was the most distinguishing feature between the real stimulation and the sham. So we were hereby able to successfully unblind the data by just looking at the heart rate on the individual level. As I think it also shows you and visualizes to some degree how profound the effect with ITBS actually was. So quite promising. So interestingly, with this study, we could extend the findings because if you would expect this to be mediated by the parasympathetic branch, you would not only expect effects on heart rate, but also on heart rate variability and blood pressure, which is actually what we demonstrated. We found that the active ITBS results in an acute suppression of blood pressure, a lower blood pressure, and an acute enhancement of heart rate variability. These effects were not sustained, so even over repeated stimulation, it was the same finding from the beginning to the end of treatment, and there was no treatment interaction present here. What was very exciting here was that we also imaged the amount of heart rate deceleration at the first session and contrasted that to the amount of improvement clinically. And here we see the first, I think, preliminary evidence that when you show more heart rate suppression on the first session, that your likelihood of benefiting from treatment is actually higher. So suggesting indeed that there could be, that we could be targeting the right area that is measured by this heart rate deceleration. On the right-hand side, you also see that the amount of heart rate deceleration was way more profound with the ITBS relative to the 10 Hertz. So on average, 8 BPM of a reduction with ITBS, whereas with 10 Hertz, it was only 2 BPM. And so quite a profound effect. So therefore, we decided also after consulting with the IRB to change our ongoing study to switch from 10 Hertz to ITBS, because the ITBS effects were way more profound. So I'm glad we did, because something very surprisingly occurred. And here we see the results of, on the right-hand side, the NCG-ITBS, and on the left-hand side, the NCG-10 Hertz. So when we look at the cross-sectional results, as we saw before, FC4 and F4 were most specifically associated with the reduction of heart rate for the 10 Hertz. When we look at the ITBS, we see a completely different topography. We see that the FC6 and F6 are associated with a very dramatic decrease in heart rate, and FC4 and F4 not that much. We also had 10 people that underwent both the 10 Hertz as well as the ITBS version, and there we see it even replicated. So it's not explained by inter-individual differences. And so this was quite a big surprise to us. Interestingly, well, not so interestingly, but we also found way more adverse reactions. And so these were all healthy people. We stimulated them with ITBS in all the different frontal locations, and 5 out of 30 discontinued the experiment due to side effects. And the side effects range from being intolerable pain, but also especially very sudden emotional outbursts. And so for some reason, I think the physiological relevance of stimulation is showing quite profound effects, but also translated into, I think, side effects and adverse reactions. So the current conclusion here is, I think the 10 Hertz NCG-TMS is very well validated, replicated, and I think a very solid method at this point in time. While for NCG-ITBS, I think we currently have to wait for more research for both a safety perspective, as well as we need to understand these data better. Are we stimulating a different area? Or, and I'm thinking that might be actually happening, maybe there could be a site by frequency interaction. That specific areas in the brain are more or less sensitive to specific types of stimulation, and that maybe the theta burst stimulation is targeting the same network, but then in from a different angle. And these are all things that we need to investigate in more detail. But I think for now there's more differences between ITBS and 10 Hertz than there's also overlap. So that brings me to the end of the talk, and I think you might have guessed this to some degree already. We talked a lot about treatment stratification, and I think this NeuroCardiac-Guided TMS is now opening up the gates as well to maybe start applying some level of treatment stratification within rTMS treatment. We know that the 5 centimeter rule that will roughly be targeting on the average FC4, the beam F4 method, which will roughly be targeting the F4 location, have been used quite often. We know that there's no harm done by choosing the 5 centimeter rule or the beam F4 method, from looking at the Carpenter and the Bloomberger study, for example. So I think that potentially, especially shown by the data as well, that we can use these two locations, probe them with the NeuroCardiac-Guided TMS, and that site that results in the lowest heart rate deceleration could maybe be the optimum to pick. And this is something that we've already implemented within the NeuroCare group clinics, where we're already applying this to some level and simply selecting between the two known sites based on the amount of heart rate deceleration. No harm will be done, but I'm thinking, and that's something we'll be actively investigating as well, that it's a very likely way and possible way of enhancing the clinical efficacy on the group level as well. Thereby, I want to summarize it to rTMS psychotherapy. I think we have to think more about combination treatments, and the rTMS plus psychotherapy is just an example. You could imagine that for a stroke rehab or for other types of disorders, combining treatments with neuromodulation, I think, is really something to consider, something to test. In drug treatments, they only need to distill the active ingredients and active effect of the drug treatment. But in neuromodulation, we're faced with a patient. I think we can also combine treatments and enhance clinical benefit. I think stratified psychiatry is probably a more realistic approach for clinical practice, as I've shown before. And I think especially because we're not denying people a treatment, but we're simply guiding people to the treatment with the highest likelihood of response, which is much more oriented and suited for clinical practice. NCG-TMS using 10 Hz strains is a well-replicated and robust finding at this point in time, whereas the NCG-ITBS is still considered experimental, requiring more research in my view. NCG-TMS is not related to percentage motor threshold, but that implicates it might be used for individual prefrontal thresholding, something that we'll be testing soon as well. And I think we can already start using and leveraging NCG-TMS for TMS protocol stratification, at least stratifying between two known targeting approaches, known as the 5 centimeter rule and the BEAM F3 method. With that, I want to thank you all for your attention, also acknowledging all the large group of researchers we've been working with. Many of the people are involved here as well. I especially want to acknowledge Klaus Schellhorn and his team, who have been very instrumental in developing the equipment for this type of approaches as well, which I think is a very well-needed thing. And Schneider Psychomedie Centrum, where we did the prospective trial with medication stratification as well.